Hello, everyone. Hi, everyone. Welcome today to Healthcare When Disaster Strikes. We've got a great seminar for you today. I'm really excited to hear our speakers. Our first speaker is Dr. Condon. He was elected to Médecins Sans Frontières Australia Board in 2011, and Dr. Condon was elected president in June 2014. Dr. Stewart Condon is a medical generalist with a diploma in paediatrics. He's worked in emergency departments around New South Wales and Queensland as a rural medical practitioner in indigenous communities of Central Australia, and also has experience working in Sydney's prisons. Stewart has done various field placements with Médecins Sans Frontières since 2014 in Sudan, Indonesia, Pakistan, Sri Lanka and Bangladesh as a medical doctor, a field coordinator and a country medical coordinator. He currently works in emergency departments as a senior non-specialist and continues to support the Central Australian Remote Health Team by on-call work when necessary. Please make Dr. Condon feel very welcome.
I'm happy to speak without the mic, but if we are recording, I'll put it on like that. And I'll just hold it like this and I'll just check that I can do that, which is good because I like to walk. And thank you for having me. Look, it's something actually I think is common for a lot of doctors when they're a few years out. They actually reflect on medical student experiences and experiences at university. Generally, a lot of us do it. We end up saying, oh, it was that day that I actually realised I wanted to do that, or it was that session where I got absolutely punished in theatre that I realised I needed to do vascular surgery. There's a sense of giving back sometimes, and I suppose that's what some of us like to do and give a bit of inspiration. Long story short, I've been to a couple of these presentations when I was a medical student, and now I apologise, I went to New South. I apologise for you. It's better. But it's certainly one of the experiences I remember where we had an MSF speaker. MSF in Australia was very new. It had been around for a good 20, 25 years, and MSF Australia was new in the 90s. And I heard one of the doctors who was actually talking about their experiences in the field, and I realised, yeah, that's what I wanted to do. Reason being, I wanted to be a doctor for a while, but certainly I wanted to do it where the needs were greatest, and I wanted to try to have the biggest impact. I probably, without sounding too corny, I wanted to make a difference. Yeah, we all talk about it. We all try to find different ways to do it, but it's one of the things that I think I've tried to do whatever I've been doing in my work. So working with MSF, it's been a very special experience for me. I went to the field 5 times in different countries, conflict settings, neglected diseases, in coordination positions, as you've heard, but also in positions which are straight clinical, which are just as important as much as the political arms of MSF, which you might have heard about as well. I've got a short presentation, I apologise. It's actually from another apology, from another group, but what it's talking about is just a few stories from the field. Now, for MSF disaster, I suppose that's the first point I wanted to make. Disaster has actually got a different definition for us. So disasters or catastrophes or whatever you would like to call them, we broaden the definition. Many of them are floods, cyclones, earthquakes, but many of them are man-made as well, and we find those probably just as challenging as the natural disasters. So when we talk about disasters in MSF, we talk about natural and man-made disasters. The way we approach those is quite different practically in the way that we implement healthcare in the field. We treat patients, but from a political point of view, we try to make sure that we're witnessing what's happening in the field. So we're happy to give medical treatment to someone who's been in an earthquake who needs surgery, but we're also very happy to treat a patient who's been in a war and broken their leg or needs surgery just as much. Yeah. So for us, disaster is a very broad definition. That's the first point I just wanted to make. Secondly, you may have heard about MSF, so Médecins Sans Frontières, you know, it's the French, it's Doctors Without Borders. We're Sans Frontières because in the beginning, a group of doctors and journalists found it very difficult to work with the International Committee of the Red Cross in Biafra, so the Belgian Congo. They couldn't cross the enemy lines. They couldn't get across to the other side to treat patients that they wanted to treat. the Red Cross had firm principles that they weren't allowed to do that. So they formed a new organisation to cross borders effectively, to be able to have that freedom and sense of patients over there just as important as the patients over here when it comes to healthcare and needs. And that's how it was born. Some principles behind it, poorly lit, but neutrality, impartiality and independence. The organisation has some quite clear, principled ethics behind it, and it does relate back to medical ethics a lot of the time, but a lot of the time it's also about the patient at the centre of what we're trying to do, or a population in danger, or trying to approach a context or a group of people and treat them as you would treat any other, regardless of their political beliefs, regardless of their religion, regardless of ethnicity, everyone being the same. It sounds normal, because that's what we do here in Australia, right? That's exactly what you would do in an emergency department or a hospital or a GP clinic, but in many parts of the world that doesn't happen, and people don't have access to free healthcare. They don't have what you expect as normal here. So that's what MSF is trying to push wherever we go. We work in a number of countries around the world. Last counts around 70 countries. This map's a little outdated, but similar picture this year compared to last year. And you can see our nearest neighbour, Papua New Guinea, as much as the African context, which we always like to talk about. We want to talk about malnutrition. We want to talk about the war in Central African Republic, a country you probably don't know much about, but it's right here in the middle, and there's a war going on there right now. There's a war in a number of countries around the world which we don't talk about in Australia. We don't find easy to talk about. Now, I don't want to get into Australian media, but there's a lot of reasons behind that. They're very difficult, complicated conversations. MSF works in these places because of medical humanitarian needs. It's a medical humanitarian organisation. So it's not just healthcare delivery, it is a broader idea of what a doctor, a nurse, a physiotherapist, a surgeon, an anaesthetist can do. We always have large teams which involve medical and non-medical staff. We've got administrators, we've got people who know how to do the books and be accountants. We know how to have people who can do HR and get recruitment happening in the field. And we've got logisticians who are probably the foundation of the organisation. They're the ones that set up the tents and get the water clean and make sure that latrines are functioning in emergency settings. They're probably the ones that I tip my hat to the most for MSF. If we didn't have the logisticians, we wouldn't be able to work in these countries. A couple of short stories. Short because there'll probably be a few questions, I hope, coming out of these. And when I put 2005 up there, I feel old. So take you a couple of steps back. I graduated around 2000 or so, more or less, 99, 2000. So I did my junior years just outside of Sydney. I did a year of paediatrics, and then I worked out bush in the communities around Alice Springs. And so I was there for a 6-month period, a short contract, and then I went to Sudan. So I hadn't really got much under my belt. I knew how to take care of patients generally. I'd obviously been working in hospital settings or clinic settings and relying on experienced remote area nurses, but I didn't have a specialty. I certainly wasn't qualified in anything particularly advanced at that stage. I knew how to take care of myself in a remote setting though. And so in Sudan, that's exactly what we had to do. This is a clinic where I was working for 6 months. We had 160 beds there. I started in the hot season and finished in the wet season. And at the front you can see these tukul structures. This is the outpatient department. These are the inpatient areas. That white tent, that's the ICU. It's called an ICU or an intensive care unit because in there you can actually run a drip and have it accurately run. Although there's no syringe pumps, there's just nurses who actually can count drips because they're numerate. Otherwise the nurses on the ward have limited literacy and numeracy, but we would need them to translate with the patients and take care of the patients, yeah? So our ICU is a different ICU to what you might see around the corner at RPA. Up the back, the main reason I was there was our tuberculosis and Kala-Azar ward. And fascinating diseases, tuberculosis, obviously. We've got more experience now recently in Papua New Guinea. We're getting drug-resistant tuberculosis, a real worry worldwide. In this area, we hadn't seen many drug-resistant cases to this point, but the most interesting part of my work was Kala-Azar. Who knows Kala-Azar? Anyone? Apart from you. Tim's an infectious diseases physician. Kala-azar is a very interesting disease, transmitted in this region by a sandfly. And look, it's visceral leishmaniasis, so it's a parasitic infection. I know that you'll probably be able to give a better, more complete definition, but ultimately you become anemic and 95% of the patients will die. It's treatable. There are treatments for it, and certainly where we were, there was a 30-day course of intramuscular injections which you could treat it, but the complications from that treatment were incredible. Pancreatitis, even mortality from the treatment itself. So we were trying to push for a more advanced treatment, liposomal amphotericin B. So a good treatment, ambisome. And we knew it was expensive, it needed cold chain to get where we were, but we knew that was important. It was an expensive treatment, but I tell you the results were incredible. I remember a 9-year-old boy who really was looking quite unwell, and I was thinking, well, look, 24, 48 hours, he's going to pass. We found some ambisome, we got a good supply. We decided, because we had limited stock, that this was a patient that probably needed it the most, and we tried to give that to him, and within a day, he'd already improved. Within 3 days, he was walking around, and within a week, it was amazing. It was just an incredible turnaround. And so for us, this was the disaster of Sudan. I bring it back to disaster because that's the theme for today. Sudan was a disaster. It was 20 years in civil war. It was a conflict between the north and the south. And where I was working was right on the border between the north and the south, the Arabic north and the more African Nuer and Dinka and local tribal south. And it was a fight over oil and territory. And it was exactly these people that would suffer because they didn't have access to free healthcare. There was a hospital clinic 2 hours up the road, close to one of the oil company sites, but you have to pay. You'd have to pay money. So the local population, again, they don't have money. It's all based on cattle. And it was a really tragic situation which had gone on for decades, literally decades, until the unification of Sudan, where things had improved. But more recently, in the last couple of years, things are a little bit dodgy again. So Sudan representing a disaster of a different sort, but certainly medical care just as needed there as anywhere else. And that's the cows. This is one of the bridges we would take when we drove to work every day. So we lived in a small village about 20 minutes drive away. Reason that was set up a year and a half before I'd arrived was when the project started. They set up the compound, so the compound is where the expats and the national staff would live, separate to the hospital because conflict was ongoing. There were local militias who were interested to find boys and bring them into their militias to do all the things that military operations do to get territory, to exert power and fear. And 20 minutes doesn't seem like much, but it actually allowed for the teams to be separated from the hospital and the more acute area militarily. Cows and cattle, I've got that photo there because it probably doesn't represent a disaster, but it's the currency. So it's a local currency, and if you were to knock over or kill one of those cattle, then you're up for a lot of expenses and political problems locally. That's the classic photo of one of the MSF vehicles as well. Okay, Pakistan. So I had a bit of time off and then went to, I'm going to do that quickly, Pakistan. So Pakistan, 2005, earthquake in the northwest region of Pakistan, also Kashmir, you might remember more as the Kashmiri earthquake. 75,000 people died in the end, a number more displaced and injured. And in terms of natural disaster, one of the biggest that Pakistan had had for years until the floods that came later, and Pakistan experiences these quite regularly. Pakistan had emergency medical needs. So I was following the emergency team, so I came around a month or two after the initial emergency team had set up. The hospitals were set up. We had inflatable tents, in fact, that allowed for surgical capacity, recovery rooms, orthopedics was what we were doing in the end, as well as some emergency medicine. And the impact was noticeable. We worked and supported the local hospital, which was literally crumbling and unsafe. So the structure itself wasn't able to be used. We wanted to make sure that people could work in safe environments, but that patient care could continue. This disaster was really it was the second natural disaster I'd experienced, so this was my third mission, but one of the most interesting in a way because it spoke to the needs acutely, but the needs longer term. We had a lot of surgery done, orthopaedic surgery. We had a lot of orthopaedic surgeons cycle through. In difficult conditions, these operations were done, but a lot of them would have post-op infections. A lot of them, unfortunately, would require antibiotic treatment, physiotherapy, ongoing rehab. And our teams were hamstrung at times because of the skill sets of the surgeons coming through. I remember we had an excellent Japanese surgeon coming through. I was the project coordinator. I'm very happy to have an experienced Japanese surgeon, but unfortunately, she was, in the end, due to visa problems, only able to stay 1 week in the field. She had size 6 gloves that she needed, which we didn't have any of, and she was unwell for 3 of her days in the project. So, not many operations done. Additionally, it turns out she was actually a hand surgeon, and so hand operations were few and far between, much more long bones that we were doing. So this is a team here. Pakistani national staff surgeon, a German surgeon and a French nurse in the background. We're always talking about multinational teams. We're always interested in having national staff as the foundation of our teams in the field. 90% of our staff are national staff from the country itself. And our expats come and go. They offer some expertise, like this German surgeon, absolutely. But in this situation, it was interesting. The Pakistani surgeon had an expertise in this. So that's an external fixator. You can see the metalwork there. That's a leg. Very difficult to identify. But this, no, actually. Yeah, that's right. This is one of the Elizarov fixators. So it's a Russian form of external fixation. This Pakistani surgeon actually trained in Russia. Do you remember? Do you remember some years ago there was a thing that happened? A lot of people wanted to be taller, and they were going to Russia. Do you remember this? I don't know. Maybe you remember this. And they were going to Russia, and they'd get their legs broken and kind of lengthened. And this is the method, in fact. So if you want to be taller, we can break your legs. We'll do the external fixator and essentially stretch you out. And so what this did was it would pull out that way, and it would actually just give that tension. The callus would form, you'd get bone formation in the middle, and then for that Russian case, you'd be taller. In this case, we had a lot of complicated fractures which needed this method anyway. The distraction was necessary, it needed good bone formation, and there was a lot of limb shortening that we were trying to prevent in cases where amputation wasn't necessary, and a lot of complicated cases. Certainly, as a disaster, an interesting one because it's a surgical approach. Surgery is becoming more prominent in natural disasters. It's really good that this is happening, but it's technically very tricky. And as a non-surgeon, I was very impressed by what was being done in the field. It's quite amazing. A disaster of a different sort. So this is post-tsunami Sri Lanka, post-war Sri Lanka as well. So Sri Lanka, similar to Sudan, had a war which really went on for a good 20-odd years too, between the Tamil Tigers in the north and the east and the Sinhalese majority. The tsunami affected this region too, and this is where I was working in a place called Batticaloa on the east coast of Sri Lanka. We were there for a number of reasons. This is well post-tsunami. So in fact, this is war-related, this project. A lot of the people... So let me just give you the context again. The war had not finished yet in total. There were still Tamil Tigers in the north, a little bit of the east, but where we were, the government had cleared the area. And the Tamils were displaced, essentially. A lot of the Tamil population were displaced, and they had no access to anything really that they needed. This is a makeshift camp, which became a more permanent camp, and it's a primary health care clinic. That's exactly what we were doing. We were using national staff. There's a pharmacist and a translator and a clinician there, and they are giving primary health care to the women, the children, the men, just as much as anyone else. We worked in different capacities. We supported a local hospital too, but for us, primary health care for the displaced population was a real priority. We didn't look at anything surgical because the local surgical capacity was quite clear. We didn't look at duplicating any services like hospitals because, again, that was reasonable where we were. It was much more the displaced people that we were interested to take care of. And that's the reason why, because they were living in places like this, long coastal sandy areas with no vegetation, and these makeshift shelters, which unfortunately by a couple of UN agencies said were adequate, didn't offer protection to them in the wind and the rain. And we knew that they were getting skin diseases. We knew that they were having respiratory illness. We knew that they were definitely getting further psychological problems beyond the ones they had already as a result of living in conditions like this. So part of our action was medical, like the primary healthcare clinics. Part of our action was also logistical. So we supported a couple of these camps in water and sank wells. And in some of the communities, as the areas opened up and people were going back to the places where they were actually based, we were sinking wells in those areas, making sure they had clean water as well. You'll probably understand that water and health are quite related. Certainly in emergency settings, they're very related, but even ongoing, post-conflict, water is a key, water and food. So Sri Lanka was an interesting context for MSF. We'd worked in different places of Sri Lanka over the last, previous 10 to 15 years. We'd worked on the line between the north and the south. We'd worked on the east. We'd worked in the north itself with the Tamils in the north, the way that we'd worked in the east. We're always going to be interested in being neutral and impartial. Having said that, this population was much more interesting from a medical humanitarian need point of view, because the Sinhalese majority, in fact, had it covered, and they had medical care, and their clinics were functioning, and they had staff. If I compare somewhere like this compared to a hospital setting or an urban setting in Colombo, worlds apart. So for MSF, we will go where the needs are. And that's one of the interesting things about what we do regarding disasters. We're always going to be interested to help, but we don't want to duplicate, and we don't want to just go out there just to do something or to spend a budget because we've got institutional donor like AusAid or whoever it might be, because they've given us money, we have to do it. We're much more interested to target the healthcare, the actual delivery of what's necessary to the right people. And if it's not necessary and that we don't see any needs, we'll only stay for a short time. Nepal is a good example recently. Although we did good work in Nepal, we didn't stay forever, and we've actually closed that project almost completely now after the recent earthquakes. So Bangladesh, look, in some ways it represents a disaster. Bangladesh has been called a petri dish for epidemiologists worldwide, where they can go and do studies and study stuff, because the government is very interested to get donor money, and research institutions exist, and the needs are there. Regarding disasters, so this is actually a non-disaster picture. It's a stable context. It's actually a Colour Azar program we were setting up in Bangladesh. It seems like all of my MSF work is on Colour Azar, this bizarre niche disease, but it's not. The program was in a very rural setting. What the team are doing there is talking to the people from the village and trying to explain to them what we're doing, why they are there, why there's obviously these foreigners who are not speaking Bangla, but what the plan would be for the next weeks and months, where they need to sensitise the population, get them to understand why this group is coming in, wanting to test them for a particular disease, wanting to record all their details and offer them treatment. The two other projects in Bangladesh were different to this. So this was a new one, and we were just setting it up when I was there. The two others, one was in the south near Cox's Bazar. Has anyone travelled to Bangladesh as a tourist? Some people have. Not many today, no. Okay. In the south, there's a place which is a very touristic area called Cox's Bazar. It's historical as well, but near there's a place called Kutupalong. And Kutupalong is a horribly tragic place. You might have heard of the Rohingya refugee coming across from Myanmar, Burma. Look, that's a movement of people who are essentially stateless in Myanmar, and they came across to Bangladesh. A lot of the group in Kutupalong had travelled across in the 90s to Kutupalong, but the Bangladeshi government didn't recognise them either. So essentially they're stuck. They won't go back to Myanmar because Rakhine State doesn't recognise them and actually perpetrates a lot of human rights abuses on that group. and Bangladesh wasn't really happy to keep them, so they stayed where they were. The project we had in Kutupalong involved around 25,000 people in a makeshift camp in a place which had no services whatsoever. The Bangladeshi government wasn't interested to support or use money for, and these people were living their lives. There were actually generations going through this camp, and it's a hill of mud. It's a hill of mud, and they've had donations, and they've had non-government organisations come through over the years and give them plastic sheeting and things for shelter, but it's an absolute disaster zone, and they're having births there in unclean settings. They're suffering from acute and chronic illnesses. It's an absolute disaster zone. So MSF in that setting was providing a full complement of care, obstetrics and gynecology, primary health care, secondary health care, referrals, anything and everything in that place. The third project in Bangladesh we had was a remote healthcare setting in the hill tracts. So again, a very remote population with poor access to healthcare, not really disaster related. I'm trying to bring things back to disasters. Disaster, disaster, disaster. We like to do this, and I'll do that very quickly because it's not really disaster related. But MSF is an organisation which I haven't really touched on it much so far because the focus I think today is a bit more on healthcare delivery and what people can do in the field, what we do in the field. But for MSF there's another element, and it's a French word called témoignage. Témoignage. Any French speakers in the room? One. Témoignage? Témoin? It's like yeah, exactly, right? And that's what a lot of French speakers say to me as well. I know what it means in French, but it doesn't really translate into English. To be a témoin is like a witness, like that. Témoignage is witnessing, more or less, but it's not really a good translation. It's a word which is integral to what MSF does in the field, because as much as I might treat a patient in Kutupalong and be able to like give a Rohingya refugee medical care or deliver a baby, there's another element which is missing, and that's the element which is very well reflected in social media these days more and more. It's the social element. It's the fact that we're human beings on the same planet, and we should be sharing these stories, and we should be sharing how important it is to know that there is someone who's had a tsunami and wipe out their village. So we should be able to know and understand better why Sudan has had a war and why someone might suffer from Kala Azar if they've only got 3 cows in their family and they've got no currency and they have to move and move and move. Témoignage is this element of witnessing to MSF's work, which is why you might hear the medical stories, but you'll also hear the contextual stories that MSF will tell as well. We might be in a position where we can tell you, okay, this is a war which is happening and we're doing these number of operations and this is what we're doing or what it might be. But we'll also say, and this is why this population deserves to have their story told. Yeah, and that's témoignage, and that's the witnessing element of MSF. All of our field workers are encouraged to tell the stories, to actually write it down or put it on social media or to tell their family and friends as well, yeah, which is a good first point. Start. We're all over social media apart from Instagram, which is a little bit weird, but that's just me. Facebook we're on, MSF is on Twitter in a number of different ways. You can find MSF Australia, I'm on there, and internationally we've got a number of different Twitter feeds. YouTube, we've got a channel, MSF TV. It's a couple of years old now, but it's interesting because there's more in-depth interviews. So if you are interested in TB, for example, there's a couple of interviews with TB experts about how TB is going to pan out over the next 5 to 10 years. Really good kind of background stuff, as well as the contextual stuff. So certainly MSF or Doctors Without Borders, we look at disasters in a very broad way, where we're interested to tell the stories medically, but also from a humanitarian point of view. It's exactly what we believe the idea of disaster relief should encompass. There are those in the field who see it as a much more narrow, kind of specific role that needs to be played. It's just healthcare delivery, but certainly MSF doesn't see it that way. I'd be remiss if I didn't say thank you. And one last point, which is in the media at the moment, you may have heard that one of the MSF hospitals in Afghanistan was recently bombed. That's a story which for us is very important. We've had staff, patients and their families which have been called collateral damage by warring parties. Now, For us, that's important we tell, because that's a terrible story, and our hospital's been bombed. It's awful. We can't do the healthcare delivery. But similarly, we also need to remind ourselves and the world there are laws of war. The international humanitarian law exists, and you don't bomb hospitals. There are Geneva Conventions, and there are things that should be respected. And even if we talk about a building which may or may not have combatants in there, MSF doesn't have guns in their hospitals. We're not a party to a war. It's a medical facility. So for the people in Kunduz who are suffering at the moment, we feel their sympathy and offer condolences, but we're also pushing to make sure that the world community recognises an investigation needs to be done, it needs to be independent, and we need to get to the bottom of what's happened. So, voila, that's MSF, and maybe questions at the end, or now? What would... Now? Questions now? Okay, cool. Yeah.
I heard one of the legal counsels on the law report on radio national last week, and she was speaking about the need to negotiate with all the different parties in an area that you're going into. You mentioned in Sri Lanka you were kind of providing services to a group of people that was not supported by the government. How did that negotiation go?
Government were okay to have us there, though they were approving visas, they were allowing expatriates to move in and out relatively freely. The extra element is we negotiated with the locals as well, so there were some militias locally that we wanted to make sure they were aware of our presence and what we were doing for the local population. They were very happy to have us there. In some places the government can be quite strong and they will refuse entry. Pakistan's an example recently where we've had a lot of expatriates movements in and out of the country blocked and their visas haven't been approved. Sometimes we are pushed to compromise our principles. So Sri Lanka 10 years before this, 10 years before I was there, there was, a different story. After I was there was a push to have an agreement between MSF and the Sri Lankan government that we wouldn't speak out about anything we saw in the country in the projects that we were running. And it was a very controversial conversation. We generally, almost all of the time, will say no to a request like that. We want to make sure people have got approval that we're there, and also particularly for the people we're treating, the communities we're in. We want to make sure that they know what we're around for and why we're there. You will see in the history there's allegations of spying and that MSF is with the CIA and doing things like that, which is a little bit far-fetched. But if people don't understand why we're in a particular place, that can happen. There's a miscommunication. So we try to make sure everyone's on board. Yeah.
So when you go into places of like armed conflict where there is like civil war happening, how do you, like, what is the policy about treating do you treat just anybody who comes in, or do you treat like civilians purely?
Yeah, so good question. Typically we'll treat civilians, but if we've got a group of soldiers come off the back of a ute and they say, well, they've got injuries, we'll treat them just as much. Where it gets complicated is if the other side brings in a ute of their guys, it's typically guys, and they say they need treatment as well, we'll treat them just as much. What we try to do is make sure they take off their military garb, generally, and there's no guns in the clinic, and they recognise also on their side that when they're in the hospital and in the clinic, it's a neutral, protected environment, and they're there just for medical treatment. They're not there to have a fight. So if there is a situation where there's two opposing sides, two soldiers in beds on the other side of each ward, that they recognise, look, they're just there for treatment. But absolutely, we'll treat anyone. Yep. There was someone nearby. Yep.
So, with the negotiations on, do those fall through for the doctors and nurses?
If they fall through and...
Do they fall through? Have they fallen through for you?
Sometimes, yeah. And MSF's been kicked out of countries. Remember, Ethiopia in the 80s, as much as everyone wants to remember Bob Geldof and what the Western world did for Ethiopia, people forget that some of the aid was diverted to interests of the Ethiopian government. MSF spoke out about that in a very tough way and was kicked out of the country. So sometimes governments will just say, look, thank you for your opinion, but you're out of here, you know, and that does happen. Negotiations can fall through, absolutely. MSF's it's an organisation which has been around for 40 years or so now, but we're not negotiators. We just want to like treat patients and be there where people need treatment and attention. So sometimes it doesn't happen to the best of our abilities. We try to make sure in all of the contexts and all of the projects there are memoranda of understanding between the government or the local government and us, who does what we can do, what we can't do. But yeah, it does sometimes fall through. That's when we kind of bring it back to our coordination level and our headquarters levels, where we think, okay, well, what can we do? What do we really want to do? How important is this to us? Sometimes we can't do anything if they say no. Yeah.
How long does it take in between identifying a place of need that you need to go to and actually logistically organising and getting there?
How long is a piece of string? It can be as long as 6 months, a year, between the time we do an explo mission, when we go first to a place, and it might just be 2 or 4 people who have a look around and see what's needed, and then they get it all sorted, they bring it back to headquarters, needing the approvals, etc., etc. It might be 24 hours. Yeah, if we've got a team on the ground close by, it might be even less. So certainly natural disasters are good like that, because we can react quite quickly if we're already in the country. To send a response if we're not in the country, we've got big logistical bases. You know, there's one in Belgium, there's one in Bordeaux in France, and they've got pallets of stuff ready to go. And so if they say, okay, well, I've got 50,000 people who've just been hit by a hurricane here, or you know, a flood there, they've got kits, bang, 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 primary healthcare kit, we'll get one surgical kit, we need shelter, we need to put on a plane, it can be there in 48 hours. So it depends. It depends. We try to get it happening as quickly as possible. A lot of the other organisations, to give a comparison, will, in that situation, if they go and they see the natural disaster and they see what's happened in the field, they'll have to go back to their donors, and a lot of them are institutional donors, people like ECHO or USAID or AusAid in the past, and say to them, okay, so here are the needs and this is what we've got in a report, They have to justify their costs before they can get the money, before they can do any of that. One of the strengths of MSF internationally is the vast majority of our donors are individuals. We've got cash on hand and we don't need to justify it to anyone else. We've got this sense of independence about what we can do on the spot.
I just have one more question and then we'll take questions at the very end.
Sure.
I was just going to ask what your advice is to students who are interested in working with MSF, because I imagine that lots of people here are, but I do frequently hear that it's quite difficult to actually get involved with.
Okay, advice.
I know it's like a really hard question.
Yeah, stay interested. If you're just talking about medical students, I don't know the percentages, but the vast majority of people will either within 5 years or 10 years be a specialist or a GP or on a training program. If you're interested in MSF, it's a very alternative career path, yeah? And you'll find yourself very quickly part of a select group already, so you've self-selected. Show to yourself that you can do it in a way. So I mentioned my story at the beginning. I've worked in Central Australia and I worked in some of the communities. That was great because I needed to know I could do it, yeah? I needed to go to a place like Yuendamu, 300 k's northwest of Alice Springs, where it was just me and 2 remote area nurses. I needed to know that I could cope with that kind of isolation and self-awareness, you know, of what I could do and couldn't do. Look, a lot of people recommend study, you know, doing a Masters of Public Health, Masters of International Public Health, that's good. It certainly shows interest in the field, but if you're interested, keep it up in as many ways as you can and get as many different medical experiences as you can as well. Okay. Thank you.
Thank you so much, Dr. Condon. So there'll be time at the end as well to take some more questions, hopefully, and for you to mob our speakers. So Dr. Timothy Gray is an infectious diseases physician and microbiologist who works at Concord Hospital. He's a member of the Australian Medical Assistance Team, AUSMAT, and AUSMAT is an Australian government-funded organisation that deploys in response to national and international disasters. Tim was part of the national teams that deployed to Pakistan following devastating floods in 2010 and to the Philippines in 2013 following Typhoon Haiyan. Tim will talk today about these deployments, including all of the logistics. Please make him feel welcome.
So like Stewart, I sat in one of these sessions when I came through Sydney University. I did a science degree here and I wanted to save the world. I studied malaria in the pathology building down Blackburn building for a year and then went on to study medicine after that. I remember sitting in one of these evenings listening to someone from MSF talk and very much desired to go down that path. And look, I've had some great opportunities. I'm going to share some of the stories of how I've ended up being involved with some disaster responses. I'm just going to get this a bit better organised. Can you hear me okay at the back? Great. Look, in terms of the, I've got lots of pictures and very few words on these slides, but I'll start with the words. And just a bit little about the Australian Medical Assistance Team. So if you think back, 2002, there was the first of the Bali bombings that happened in Bali, and it caused a big response in Australia and reflection afterwards, because the Australian ability to respond to that was praised at the time as being very efficient and very effective. But it highlighted that there could have been more services available to reach out to that part of the world when disasters happen, not just affecting Australians but other populations as well. And then following up from that, there's a Boxing Day tsunami as well. And it was that in that context that the AUSMAT teams became more professionalised and more set up by the states of Australia in being able to respond to disasters. So AUSMAT, as an introduction, is a civilian medical team, so it's truly multiply disciplinary. We've got, they've recently reached out to get physios involved as well as part of the response. I say my wife's a physio, so I've got to include them. But no, in disaster response, there's nurses, there's paramedics, there's doctors, there's logistics staff, often firemen in background. That respond. So doctors make up a small part of probably about a quarter of the team response. If you go with AUSMAT, you've got to remember you're part of the Australian aid response, so quite different to MSF. When the Australian government says we've spent $20 million in the disaster response, some of that bottom line is paying the expense to get you to the disaster and for your accommodation, shelter and all those expenses. So it's part of you're part of the Australian government response. And there's some limitations that happen with that. There's in terms of dictating where you go and how you respond as well. I haven't found them personally challenging at all, but for some people that there might be limitations. I'll highlight some of those that occurred in the responses. It's a group that tends to be a rapid response at short notice, so I'll talk about my response to these disasters and how that occurred, but usually within a week of the disaster we're on the ground. Usually within 48 hours there's someone from the government assessing things, but we can't respond the same way that MSF can, but usually it's a pretty rapid response in terms of other groups on the ground. So I work for different government departments around Australia in my training, and when you go with AUSMAT, you're actually seconded to the Australian government from your state employer. So you're still employed, you're still paid your regular wage, but you're seconded away. So it's actually a nice way of being able to maintain response to disasters as part of your career with AUSMAT, because you're still employed and you can still do it as part of a structured career in Australia. In the mainstream healthcare system. So the National Critical Care and Trauma Response Centre is situated in Darwin, and that's how I became involved with AUSMAT, was from working in Darwin. And this response centre was set up after the Bali bombings and the tsunami, and essentially it's similar to what Stewart described with the warehouse. There's a massive warehouse in Darwin that has all the capacity to respond with the equipment, so it's all there in pallets and with forklifts ready to take it off. It's got everything to keep the team fully sufficient in terms of shelter, food, water, all medical supplies and communication equipment as well. So that essentially goes off the shelves onto the plane, and then we deploy from there. So that centre is funded by the federal government, but the staff are seconded from the state employers to respond. So AUSMAT responses throughout recent, since this isn't all of them, but this is the main ones they've been involved with. So it's not that often, I guess, is one of the comments, one of the insights from looking at this slide. But the Boxing Day tsunami is one of the first ones where the AUSMAT was part of the response. There was the Samoa earthquake in 2009, the Pakistan floods in 2010, which I'll talk in more detail about, was one of the ones I was involved with. In Solomon Islands in 2013, there was a dengue outbreak. I would love to have gone to that, but I was getting ready for my microbiology exams at that stage. It wasn't the right time for me to go. Cyclone Haiyan was after my exams were all finished, so I went to that. The Philippines, as you know, probably remember from the mainstream media, the biggest storm to ever hit land hit there, and I'll talk in detail about that response. And there's been other responses to the Solomon Islands and Vanuatu. I guess one of the other things too to think about in that response list there, that when the AUSMAT responds, it's not just about the humanitarian need. It is very much about that, and the hearts are very much in that on the ground. But it's also part about the political response from the Australian government and I guess the political agendas of what was originally AusAid, or we call it WasAid now because it doesn't exist anymore. But it's now it still sits under the DFAT, the Australian government. So these responses are very much about the Australian government wanting to show they're responding as much as the response itself. I guess it's a double-sided coin. So look, I'm going to talk a little bit about Pakistan first. In 2010, the red dot there in the middle is where we were deployed to, right in the middle of the country in a place called Kotadoo. We flew into Multan and deployed to there. So it was in July 2010, so 5 years ago actually. I was in the Oval in Pakistan. But the storm started in July, and there's first international reports in late July 2010 of some flooding in the country. And the rains just continued, and the floodwaters rose. And at the peak, actually, 1/5 of the country was underwater at one moment. And over 20 million people, so Australia's entire population equivalent of, was displaced from home. There were about from the homes. There's about 2,000 deaths reported too. So in terms of natural disasters, not a huge death toll, but in terms of the people being displaced from their land, having their cattle, their crops completely destroyed, it was a massive financial and humanitarian disaster from the economic side and the human toll side. And it was described at the time by the head of the UN as a slow motion tsunami, essentially, in terms of the disaster cost. It was that's how it was described. That shows a whole fifth of the country underwater at the time. So I was very naive about floods and what they do to homes. I never understood. I thought the water would just come up gently and go down again. If you're on the roof and got your things to the roof, you'd be okay. But the reality is with floods that the rivers break, and there's massive. It's not a photo I took, thank God, but it's a media photo. But the water completely rushes through, and that's how a lot of the damage occurs in floods. And so people often, there's often, not always, but often warning with floods, so people do get to safe land, but they lose their homes, they lose their cattle, they lose their economic livelihood, the hospitals can be destroyed. So it can be a real disaster in that sense. So the Australian, we didn't deploy, we arrived in Pakistan on September 1st, so that was about 1 month after the first media reports of disaster of flooding in Pakistan. So this is where we deployed to. This is a football oval, which is part of a power station in the middle of Pakistan. This is an oval used by the family of the staff that run the power station. It was considered a kind of a key asset of the Pakistan government, so it already had existing security walls of 3 to 4 metres around it. Being the Australian government response, they're very concerned about the safety of staff being deployed, to the point that sometimes it gets frustrating as the individuals being deployed. But nevertheless, it was a very secure environment that we were in. They were actually, what they did is the corner of the field up here, they knocked a hole through the concrete fence, and so the patients could come in and be treated at the health facility, which was at one end of the oval. So who goes on these deployments? So this is the Pakistan one. This is quite different to all the other AUSMAT deployments. This is a combined military and civilian deployment. So there's lots of military people. The majority of the logistics was done by the military people in this response. The military are extraordinary at the logistics of what they can do in such short periods of time. Is quite extraordinary. But in terms of the military, I won't read through them all there, but I guess a couple of comments. They bring force protection, so unarmed in this case, but the tough military guys that keep you safe. And they send a media person as well as part of the response with what was AusAid at the time. So it is it's to report back to Australia. This is Australian government aid money being spent, so it's reported back. And there's lots of opportunities to be interviewed by media if you're interested in doing that stuff in these responses. At the time, Kevin Rudd had been no longer Prime Minister, he was Foreign Minister, but he came to visit to the Oval, so we all got to meet with him, and the President of Pakistan came, or Prime Minister of Pakistan came at the time as well to the thing. So these high-profile people come through these responses. So these are 17 medical staff from the AUSMAT team. There's 6 doctors. I was one of those. I was only physician doctor there. saying to Stewart before, you don't want many physicians in disaster responses. You stop and think about things too much rather than getting things done. But having an infectious disease background, I think it's always good having one person with that background on these kind of responses. So this is the tents that were set up. So probably give you a better sense looking inside. These are inflatable dome tents that which were air conditioned, and we had 2 of these set up, one for female patients, one for male patients, and there was a third shorter tent set up for hospital accommodation for us and for the military and civilians responding for when we became unwell, which happened, and also for pathology. We had a little pathology unit set up there which could do simple tests, including gram stains and some biochemistry and haematological tests, and had pharmacy in that other third tent as well. So what did we do in Pakistan? This is a sign set up out the front, and through the local mosque it was all advertised what we'd do. So we provide care to those that have become sick from the floods. We have doctors and nurses available that provide basic treatment if needed, open during the day but cannot keep people overnight. And that caused some conflict within our group initially because we were sending away people that were quite sick and we're trying to get them to the local hospital, but the local hospital would charge patients money to stay there, and that wasn't always a possibility. So it caused a real ethical dilemma for us at times. In terms of having to send people away. I don't think we send anyone away to their death or compromise their care. We'd always find some way of getting them away, so somewhere where they could be continued to care for, but it did cause problems. So we treat conditions like fever, diarrhoea, skin problems, breathing problems. We do not have surgery, so we've made that very clear to the population. And if you're too sick to be treated here, we'll transfer you to a local hospital. So that's a good summary of what we did there for the 60 days that the clinic was open. So patients came through a metal detector at the front. The security was run by the local military that screened patients that came through. And there was at the time bombings going on, not immediately in this town, but only a few hundred kilometres away. There were some suicide bombings happening. Mostly the violence was directed from Pakistan to Pakistan people. It wasn't towards foreigners in this part of the country. But that was something certainly that the military were particularly concerned about, and I'm grateful the military are concerned about that and keeping us safe as well. We didn't have any security concerns in the time we were there. We used to have to practice doing a disaster a response if we came under attack, and where we go, and they used to do drills of this occasionally in the middle of the night. We'd have to have something ready, and we'd have to run, put a ladder over a fence and jump into the next section of the compound where we considered to be safe. So these are 3 tents there. You can see the patients queuing up to be assessed there. Medical records were kept on WHO kind of standardised cards to keep a record of what was going on. Every day we report to the local health ministry and to the WHO about disease rates and what we were seeing. This chap here on the left had a case of malaria. Malaria is over 700 cases of malaria diagnosed in the time we were in Pakistan, so very much more than a number of cases across Australia each year. We saw it within a month there. We had local military translators, also some local staff translated as well. They pointed out to us that the local translators were actually spies that were put in place by the military or the government there, which may well have been true, but it didn't bother me. They did a good job of translating, and it was fine. We had a pharmacist that deployed, and as I said before, we had a pathology service as well that did some basic tests that gave us an idea about different diagnoses. It can be very useful, a simple gram stain in the field. So X-ray facilities, so you had electronic X-ray facilities, digitalised X-rays. They could be printed to a simple printer in the field, and they could carry those X-rays away to be referred on. We made quite a few diagnoses of tuberculosis in patients that walked in with X-ray changes, which were new. So daily life on the camp, we called it Camp Cockatoo. So it was mixed military and civilian. But in military tents, we had our mozzie domes beneath those. I think I'll show you. So it was quite crowded, very little privacy. The day we arrived here, it was 50 degrees, and the humidity was unbelievable. And it's in the first 24 hours, 10% of the people deployed ended up in our local hospital. You know, it was the only area that was air conditioned, to be fair, and not all of them needed IV fluids to be resuscitated. But heat illness for people being deployed was a real issue, and it was quite striking. Having been acclimatised in Darwin prior to this, I think helped people from the north of Australia, but still it was quite a shock. So we ate military ration packs for 30 days. They're kind of a novelty at first and quite interesting, but they get a bit boring after a while. But they certainly keep you nourished. And these were the basic toilet facilities as well that we had. I think I've got a disgusting photo here. Yeah, so we had to have a roster to empty out the toilet facilities. So it was pretty disgusting that we had to be involved with that for the time there. So hand washing stations, we only had 2 cases of gastro in the 60 days of the deployment in the end, so I think that's a good credit to the good hand hygiene. That was despite confirmed cases of cholera that were coming to the clinic. We had at least 15 cases of cholera that came through the clinic, so I think it was something that's a good thing. And that's a patient hand washing station to the right. I guess one of the other things, having the logistics of the military around too really helps in terms of environmental health. So we know that people being diagnosed with malaria just 50 metres from the front gate of the healthcare clinic, yet no one on the field was diagnosed with malaria from the deployment. And part of that is around the fogging that was performed to treat mosquitoes or kill mosquitoes, trapping of mosquitoes to identify what mosquitoes were in circulation, and directing fogging towards areas where they were finding more mosquitoes. And they were doing larvicide bombing of local water supplies too, making them not possible for mosquitoes to live. So I guess it's part of the thing is when we respond. MSF had the same logistics too. I don't mean to make a comparison, but the Australian government is incredibly concerned about our safety. We weren't allowed to leave the Oval for the whole 30 days, even though there was a great desire that we wanted to do that, to reach out to do clinics to areas. We felt that where we were located was really suboptimal because there's essentially no transport available unless people had money to come to the clinic. So it was limited in terms of what we were able to provide in the middle of the country. So I guess there's those kind of limitations that being able to respond. The request went back to Australia to seek permission to leave, and it was almost granted at one stage. And then there was an episode when the military went out where they got crowds came around the car. I don't think they felt threatened by it, but it was enough to make the Australian government concerned that the response would stay very much within the Oval. And we did. I don't want to understate. I think we did very good work there and did make an impact on the humanitarian response. But it's a bit frustrating at times. And we used to have education sessions each day talking about uncommon diagnoses that we'd see in Pakistan and talk about treatment of those. So just a photograph of that there. So in terms of the conditions we saw, so it was over 3,500 diagnoses of malaria in the time there. Of those, I think it was about 2,300 were confirmed, of which 700 were confirmed in the month that I was there. So there was a lot of malaria diagnosed on clinical grounds, but the majority of those were confirmed with rapid diagnostic tests which we had available in the field. There was a lot of chronic illness that presented, and that happens just because there's a disaster doesn't mean people don't have ongoing health needs associated with underlying problems, and they were common. Lots of dermatitis problems associated with water exposure and from this. Some diarrhoea and respiratory infection. And injury was not very common in this part of in this disaster response, which is quite different to the disaster I'll speak about in a moment. I'll skip over that. So as I said before, we diagnosed lots of tuberculosis in the clinic there as well. So this Soccerfield clinic operated for a total of 48 days in the end. That's right, it was planned for 60 days, but the numbers were dropping off and there was a decision made by the government to stop early. And so the Team Alpha, which was the first group that responded, which I was part of, was there for 30 days on the Oval. So it was in the end at 35 days away from home. So it was a long time away to be away from home. And it completed 11,000 consultations over this time. So busier than a lot of emergency departments in terms of the workload. And I might put those reflections at the end. So just in terms of it's kind of when these disasters strike. So I didn't consider myself someone that would be particularly useful in a disaster response like this. I was working as a senior medical registrar at Darwin Hospital at the time, and I spent 6 months in that role. And then I went across to the public health unit to do 6 months in the role. It was a public health registrar, which is more a desk job. And I was going to a job where there wasn't someone for the previous 6 months. So I guess it was a bit of luck in a way that my role was dispensable. It's very hard to relieve registrars from busy hospital roles to go off for essentially 6 weeks away from work, which is unrelieved. So it was kind of a bit fortuitous. I was in a role which was a bit dispendable. And I didn't even volunteer for this when they asked for people at a morning meeting at our public health unit to respond. But someone tapped me on the shoulder and said, would you like to go? Previously, I'd worked for a year in East Timor. Halfway through my medical degree here, I decided I hated medicine. I was working at one of the very big clinical schools and found it very impersonable and very big, and had a kind of a crisis, will I continue to study medicine? So I took a year off and went and worked in East Timor for a year. So I'd worked in a developing setting before. So similar to Stewart, I'm very an advocate. People interested in this type of stuff, follow follow your passion. If you're not passionate, follow your curiosity in terms of this stuff. And I think that's the kind of way it can lead you to a path. How am I going in terms of time? Is I've got
Yeah, good time.
Yeah. 20 minutes, is it? Okay. What questions is? So I'll go about 10 more minutes. Okay. All right. So I might switch. Any questions on the Pakistan response? 'Cause I was going to move away from that now and talk about the another disaster. If there's any comments or questions? Yeah.
So you said after malaria, the most common clinical presentation was chronic diseases. What were the main chronic conditions that you saw?
Yeah, so the reality is people saw a foreign hospital set up and they go, well, a foreign hospital might be a really great way to get my conditions treated, and they might know more than what the local doctors know. So people came with all types of problems. So with arthritis was a very common one. With heart failure was another common one. With COPD or tuberculosis was other common ones as well. So similar presentations you might see in Australia. So that's in some way people on the field were getting frustrated by this because they're saying we're here to respond to a disaster, yet we're treating chronic illness. But I felt these are people still in need of care. One woman came to us. I remember I got into an argument with one of my colleagues there, but a woman came with us who had a CT scan from a hospital she'd been to, and she had a weak arm, and she had a big lesion in her brain that looked like tumour on the scan, and so she came to us for a second opinion for this, and I gave her some prednisolone to treat it as a possibility of a tumour, thinking it might respond to that to give us some more time in terms of a response. And my colleague was saying, it's not what we're here for, we shouldn't be treating this type of thing. But I'd refer her on to another hospital with a letter saying, well, I think it is, and I felt that was the right thing to do. But I guess these ethical dilemmas can arise in these situations that, in terms of treatment. Yeah. Oh, yeah, sorry, go on.
Sorry. You said that a lot of your work there was sort of politically driven. A lot of what you had to do was dictated by the government.
Yeah.
Do you feel that at any point you had to compromise your ethical ethics to do what you're told by the government?
No, I never felt compromised in what we did. I think even the military guys are very humanitarian in their response. I think a lot of the military responses these days are humanitarian responses. And I think there was lively discussion around whether the hospital could keep patients overnight under exceptional circumstances. If we needed to keep them monitored or give them ongoing fluids, and we didn't have to do that in the end. But there was a couple of times where we considered doing that, and I think there was some flexibility there if we absolutely had to do that. But so no, I never felt compromised. There's some slowness in being part of government responses. So it took. It was about 2 weeks from the time the Australian government decided to respond to we were on the ground in Pakistan, and in the Philippines it was about 5 days from the time we decided to respond to where we arrived. And 5 days is a very long time in terms of people's fractures and wounds and that type of stuff. So it's so I never felt compromised, but frustrated. I just wanted to get there quicker, and I imagine it's similar with other organisations too. No matter how quick you are in getting to a response, you want to get there quicker to do things. But there's no point getting there if you've not got the equipment to do it, you've not got the logistics to do it, and not to be safe. Because one of the things that's frustrating in these responses sometimes from groups like MSF and other groups that do this very professionally, and I think OSMAT do this very professionally, it's one of their things they drive, being professional disaster responses, is one of the issues is that people turn up with very little training, very little, essentially no equipment, no accommodation, no water, no food, and they're knocking on your door saying, oh, can we have a few bags of your rations to take with us, and by the way, can we borrow a scalpel to cut off a person's leg up in the field, and which is really inappropriate kind of medicine. And it's one of the interesting things that came out of the Haiti response to the disaster there. If you look at the different amputation rates from clinic to clinic, it is even set up in the same area. Some clinics were, I forget the numbers, but some were more than 50% amputation versus less than 1% in some clinics. So you've got to think about what's the training, what's the outlook of these clinics. But it's so I think OSMAT do things very well in a way, even if it's sometimes a little bit slower in its response. So I might move on this time to the Philippine response. So I was working at Westmead Hospital at the time of this response, and I was sitting at my desk at 1 o'clock in the afternoon. My manager, one of the specialists there, came in and said, I just got a call from the head of the disaster response from the hospital. They want you to go to the Philippines. And so that was at 1 o'clock, and at 6 o'clock that night I was on the plane to Darwin to go onto the response. So it was quite exciting when this happens, and got a very understanding family, of course, for this to work. But anyway, I'll talk more about that later. But you know, so in terms of the I guess I prompted it with a phone call to my friends that work at the National Critical Care Trauma Response Centre. I saw this local disaster. I wondered if there'd be a response, so I sent them an email saying, "Oh, by the way, I'd be available if you needed someone to go." So, and that was the next I heard was this thing you're going. So that's it's quite exciting when these things happen, and it's a real privilege being able to respond to these. I know there's many people in the room who'd love to have this opportunity, and it's absolute privilege to walk with people and to witness the resilience of people in these disaster responses. So I might pass on this quickly, but essentially the Typhoon Haiyan was there's different ways of measuring storms in terms of wind speeds and whatnot, but what's not disputed is this was the biggest storm ever to hit land. Whether it's the biggest storm ever on Earth is it's in the top few, but depending on how you measure it, it may not have been the biggest, but it's definitely in the top few. But when it hit land, it was the strongest storm ever hitting land. Had sustained wind speeds of 315 kilometres per hour for over a minute. So you can imagine that that's pretty ferocious. But the wind, to be honest, is not what causes the most disaster in these cyclones. It's in terms of the real disaster here was the storm surge that came with it. So the storm hit at 6:30 in the morning. A lot of people got away from structures which were unsafe, and a lot of people actually evacuated to a big stadium in the middle of the town. But what happened was there was a massive storm front, the surge that came with the high tide. It was actually over 5 metres at parts of the town. It actually inundated the area where people had gone to be. The government encouraged them to go to be secure, and many people drowned in the sports centre in the middle of town. So these, it was a real storm surge. So it was really like a tsunami in a way that caused a real damage. And that's where Tacloban is, where that red arrow is, which we heard a lot about in the media at the time. So it was a brunt of the storm. So this is Tacloban city before the disaster. So its population is about 250,000 people. So that's slightly bigger than Hobart, or twice the size of Darwin. So by age, it's a small city, but by Australia, it's a reasonable sized city. It's a university town. Several universities there. Had 4 hospitals, 3 private, 1 public type hospital. And it used to be the capital of the Philippines. So it's like a lot of Asian cities, some very well-built structures and some non-approved kind of self-built structures as well, and they fare very differently in these disasters. So the absolute disaster or the destruction you see there is from the water surge that comes through. There's a few photos there. This photograph on the left I took driving up from the compound where we were into the city to the local hospital which we were working with, and that's the whole village from the road to the sea was destroyed, and it was absolutely horrific. You can see there the whole boats were moved by it. A very sobering picture I took of dead bodies by the side of the road and the stench of that. It's really horrible, and I don't know how much it's worth going to this stuff because I know it can be very distasteful hearing it all. But there were certainly dead bodies where we were camped that we need to be cleaned up and being found during the time there, and it's really quite confronting. So it's something if you're going to be confronted by this type of thing and be overwhelmed by it, it's something to think about before you go. OSMAT do psychological assessments and supports before you go and on return as well for it. It's not ignored, but it's something you've got to be aware of if you're going to go into these disaster responses. And it's not the visual of the bodies to my mind, it is the smell of them, which is the thing that really found it was more difficult. So there was over 6,000 people that were killed in this disaster, and the vast majority of the eastern Versailles, which is where Tacloban was located in this city. So a city of 250,000, of nearly 6,000 people died in that city. So this is a local hospital, so it was storm affected. You can see here a lot of medical records were destroyed, and I guess the point to make in these really acute disasters is it's not so much the building that matters, because buildings you can put tents up, you can sweep the water out, but you've got to remember these are run by nurses, doctors, cleaners, clerics, and they've been killed in the disaster, or if they've been able to, they've fled. And if they haven't fled before the disaster, they're sure going to afterwards, because there's no shelter there, there's no food there, there's no security there, and if you've got family elsewhere, everyone was trying to get out of the town. So the real issue in this acute disaster, at least here, was about the personnel running the hospital. The government was very good in the response to that, the Philippine government, but that takes time as well. Yeah. 10 minutes? Or, yeah, good. So I'll skip over that because I've covered that before. So this is Tacloban City. You can see out here, this is where the airport is, and there's this little apron there that's being built because they're going to try to make it into an international airport at some stage. So they built this apron, but it was never transformed into it's a close-up of it. So it was cleaned off by bulldozers. Again, there was dead bodies all over. A lot of people died at the airport because on the peninsula is where the storm surge came through, and it's where it was 5 metres high. But it was cleaned up, and we we came in and we set up our tents there. So with the AUSMAT response, it's pallets off the warehouse onto the plane. The plane needs somewhere to land, and you need a footprint. And it's not, I'll show you the picture, not a small footprint. You need somewhere that's clear where you can set these tents up. So who goes on this response? So this was a non-military response. It's full AUSMAT, a civilian response only. There was 14 doctors, including a public health physician. They're very important in these responses in terms of communication of results to the local population. Lots of emergency doctors, not enough paediatric doctors. Need a paediatric doctor in this response. And as I said, there's just one me, who's a physician, microbiologist, and you don't want more than one physician in these responses. I found myself quite useful. There's lots of complications in the hospital in patients that I could manage well in terms of discharge planning of patients, and lots of infection problems as well and antibiotic advice. So I felt useful, but physicians are, I think, less useful in these responses. Lots of local nurses. Paramedics are great at picking out the people who are particularly unwell, very practical people. And the logistics staff, as Stewart mentioned before, incredibly important in these responses. They can make life very much more manageable under these circumstances. So we flew there in military aircraft. So the military enabled us to get there with transport. These are vaccines sitting on in the hotel foyer. They've all got cold packs in there being monitored. One of the things that breaks down in disasters is the cold chain. So in terms of vaccines, which is so important following disasters, having a secure vaccine cold chain is important. That's something that the AUSMAT team was able to respond until that could be set up again in Tacloban. So here we are on this apron by the airport being set up. This is in the morning being set up, the first wing of our big H-wing hospital. This was set up as the operating theatre, and by that afternoon the first operation had been performed, which is actually an appendectomy that was performed on an older man who came in with an acute abdomen. People get surgical problems and emergencies in these disasters which aren't necessarily related to the disasters. So this is the big broader picture. So we had an outpatient unit set up here, had a triage desk out the front, which is just out of shot here. We had chairs at the front of the outpatient unit here. We had beds, about 15 beds at the back for acute assessments. People that needed to be admitted walked across to the big blue tent to the right there, which had 4 wings. One was an operating theatre, and 3 of them were inpatient units. So we had capacity about 45 to 50 inpatients, and often those beds were being used up to about 3 patients a day. In terms of turnover, it was very rapid. And that's an emergency resuscitation tent in the middle there. So the triage Department of Health sent in staff which acted as translators and as also cultural kind of interpreters for us there. They were taken from areas outside of Tacloban, so not from the area of need as such. So it's very, one of the things about AUSMAT is very much working with local population and government responses there in terms of the responses. So the medical records were kept. In interest of time, quickly. I guess one of the things that's changed in disaster responses, the records used to all be kept at the clinics, but I don't know what MSF does, but now there's a big move internationally to push that the records stay with the patient, particularly in a disorganised disaster response where people might be representing not just to you but to other responses as well. So that requires double collection of data if you need to report to the local Department of Health and whatnot. So, but these cards used to go off with the patients. We were referred by ambulance, by road, by people walking in. We're right by the airport where thousands of people are trying to get out of town and falling sick in the queues to get on planes. And the American military on these Ospreys used to bring in people from remote areas to the point where they used to give us GPS coordinates where they were from to help with our discharge planning to get them back. The roads were all closed down initially, but so we had some bed block in our hospital trying to get people back to remote areas. The military used to drop them back for us on occasions when they were going that way. So this is a resuscitation tent. We had X-rays set up in there as well. These are the ambulatory care outpatient unit where people would walk in, get assessed in the chairs. Beds for the sicker ones, particularly with fractures, out the back. This is the main hospital building, and someone being transferred from the outpatient unit to be admitted to the unit. So this is a surgical unit here. So we had 2 operating beds running and operating beds running here. So we had 2 surgeons only, an orthopaedic general surgeon and a general surgeon, and they were very, very busy. It was a surgical response, this one primarily, and they did a lot of operations, essentially from 7 o'clock in the morning till 10 o'clock at night. And the poor nurses had to do the sterilisation. We're up to the wee hours of the morning doing that, so we'll be all ready to go again the next day. I've never worked so hard in my life, and we're only there for 14 days. The first response was 14 days, and the Bravo team that came next was another 14 days. It was only a 1-month response, but it was very tiring. So we used to do rounds 3 times a day in the hospital to keep things moving along, and you can see here an inpatient unit shot. We had a pharmacist deploy with us as well, and she's sorting out doxycycline. There was an outbreak of leptospirosis which occurred following disaster. It's well described after disasters. So this is a spirochete that is in the urine of rats primarily, but also any mammals. It gets passed in the environment, and if people get exposed to water, particularly if they've got wounds, it can enter and cause fevers and can cause conjunctivitis as well as, but it also causes liver failure and renal failure. They present with high fevers. So we used to give doxycycline as a prophylaxis. So that was raised at the local health cluster meeting that all the people responding to the disaster would go along and talk about it there. So in terms of, I might finish up soon, but in terms of sterilisation, it's one of the nice stories, I think. The local hospital, their sterilisers were stuffed by the storm. They just couldn't work. So what we used to do is they'd wrap up their equipment, then bring it up to us, we'd sterilise it, then drop it back there. And it was in our interest because we did not want to do obstetrics at our hospital there. We had a death on the first night of a baby that was born, which was emotionally very hard for our team just having arrived. And obstetrics is a very dangerous medicine in the sense if you haven't got ability to transfuse or provide immediate care to babies, and it's something we decided that was the local hospital had ability to perform C-sections. They had staff there for it, so it was agreed that we'd transfer women in labour up to them. Vaccination occurred at our clinic as well, as I said before. Or these are the workers coming in getting tetanus vaccine before they get exposed to the clean-up of all the debris. And evacuation was a big part of the response as well. So in disasters, people, one of the women there has had a previous stroke several years earlier. Her family looked after her fine at home for all these years. A disaster strikes, they lose power, they don't have food, she's no longer safe there, and they bring her, please take her out. So these patients, which is not uncommon, would come through our hospital first, be assessed, if safe to go on the plane, they'd be shipped out to family or other hospitals in the country. There's a case of tetanus amongst that cohort there. Very rarely see it in Australia these days. We had 6 cases of tetanus in the time there, including one that we palliated and who passed away, which is very sad. It's an illness that can be treated effectively. If you survive an intensive care course, while the time the toxin washes out of your body, it's an illness you can survive. But at this early stage, we didn't have ability to refer on. There was no transport to get people to hospitals, so this young man was palliated. I rang a colleague in Australia to make sure I was making the right decision with his care, because these are tough decisions to make, obviously, for someone who's young and potentially treatable illness. But the subsequent cases of tetanus were able to ship out to intensive care units around the country. So terrible wounds, skull fractures. This young girl, a 4-year-old girl, had a palm tree fall on her head and had some wooden debris in it. A local neurosurgeon was visiting and actually operated alongside the Australian surgeons in the operating theatre to clean out that wound. So there's good cooperation going on. Horrific fractures that were there. That chap on the far right of the screen survived somehow from that injury. He's quadriplegic, but we shipped him out to a unit. Now, if you're squeamish, shut your eyes. I never know whether to leave these photos in or take them out. They're horrific wounds. I'm going to show you them now just briefly. But terrible diabetes problems in the Philippines, so terrible necrotising infections. People step on nails underwater or debris underwater when it's flooded and murky. So you get horrific wounds. A young boy had his foot amputated by iron coming off the roof of a house in the storm and the wind and cutting off his leg, and he had very sadly had injury to one of the nerves in the other leg as well, so he had a foot drop on the other side. One lady had her hand jammed in a door in the wind, and this one on the bottom right had a bit of timber hit the back of her leg. It was coming through the water. So terrible, terrible injuries. I mentioned tetanus already. I'll skip over leptospirosis. Lots of chronic illness there. That's a Scarus lumbricoides worm, so one of the most common parasites in the world. Coughed up by a little girl on the ward while we were there. There's a case of appendicitis in a young boy, and they took his appendix out, and I get very excited as an infectious disease physician because they call me in there, I look, and there's little enterobius worms all over the appendix, which has caused his appendicitis, you can see. You don't see that in Australia very often. So life on camp, really crowded conditions. It was raining all the time. I took the photos when it was sunny, so they're misleading. Good hand hygiene, and we again lived on ration packs essentially. I think they're better than the military ones. So look, just in terms of how to become involved in disaster response, I'd like to talk a little bit about in terms of how the bit of advice on this. Who am I to give advice? I don't think I really am. But similar to what Stewart said, I think take life opportunities as they arise. Like Stewart, I worked in Alice Springs for a period of time during my training. I worked in Darwin as well, and including. And so I think follow your passion. If you don't have a passion, follow your curiosity and your career path. And don't necessarily hurry through your training. I think one of the things about being a perpetual registrar is that you do, once you stop being a registrar, you don't, or a resident, you don't have the same opportunities to slip into different teams and experience different things. So once you're it becomes your professional path. If you want to be a professional disaster response, you can do that. There's not many people that achieve that as a long-term career path. If it's your passion, by all means, go for it. But if you want to get involved, I think my suggestion is take time in your training and take up life opportunities as they come to your way. Generalists are very much more useful in these disaster response than specialists. GPs, paediatricians, generalist paediatricians, ED physicians are very useful. Doesn't mean that if it's not your passion, I wouldn't follow it just for the sake of being involved with these, which is to comment. Surround yourself with supportive family and friends. My wife's been very supportive of me going on these disaster responses, which are, can be quite an impact on them being away, not being able to respond, be on the phone. And I guess know what you want, whether you want a professional career in this or whether you want intermittent involvement. So I think that's all I'm going to say. I'm sorry if I've gone a bit over time.
Are there any questions before we wrap up? A couple quick ones.
Here we go.
You were there for the Philippines for 14 days. What kind of criteria does the OSMAT use to define when a disaster is over or resolved, and then pack up and leave?
Yeah, so I guess they do assessments before they go in, so they've got some idea of what the needs are, and it's really about getting the local hospitals back on board again and supporting them to get working again and just returning to normal healthcare needs. They're never long-term projects in terms of staying for years in these responses. So the criteria that are used is there's weekly, in fact daily meetings in these cluster response that MSF and other groups are involved with, where you come together and talk about the needs to ensure there's not duplication and to talk about what illnesses are emerging. And as part of that, you can assess what the needs are. This was in Philippines was primarily a surgical response, and so a lot of the surgical problems came through either immediately or when the transport from external areas started coming in by helicopter. So that was, those problems were mopped up quite quickly in terms of the first few weeks. And in terms of the number of surgeries, the vast majority of those were in the first 2 weeks there. So you get an idea from the number of cases. And then it happens at high levels with AusAid and the Attorney General's Department and DFAT and all those decide what the duration of the response will be.
Talking about professional and intimate responses, how easy is it for you? So if you go in and respond to disaster zone, is it for, say, a hospital to get on to, I guess, replace you in that time?
So.
Is there a lot of work that you have to go through?
Yeah, so I always feel guilty when I leave my workplace to go on the 2 times I've been on these responses, and because it is difficult in healthcare workplaces for this, and it's one of the benefits of going to something like MSF or another group where you commit a certain amount of time to say that I'm going to be out of the mainstream employment and do this alternative great things. But it's in terms of the it can be quite disruptive to a workplace. So I've been fortunate in the times I've knocked back deployments with AusMat because it's not suited in terms of timing for either my exams or workplace involvement. So it's one of the factors that does come into it. Usually people in the workplace are pretty responsive to it. The workplaces love it. You get medals. I've got a humanitarian medal from the government for doing this type of stuff. So workplaces love that. They put you in newsletters and all this type of stuff. So it's kind of cool. But so they do like it. But on the other hand, there is that practical element to it that if you can't be replaced and you're essential in the workplace, it can be a problem. Yeah. Oh, okay. All right. Good. Sorry.
Maybe if you could ask questions at the very end, or
I'm happy to hang around. Yep.
Yeah. All
Yep.
right. Great. I've got a couple more things to say. First, thanks very much, Dr. Gray, for speaking. This is very exciting for me to take part in organising, and I just want to thank both Tim and Stewart for coming and taking the time out to speak to us. I'm really appreciative of it, and this is really eye-opening for me as well. As a small token of appreciation, we've made a couple of donations on your behalf. So we've donated some money to MSF and also made a donation to GiveWell, a charity that's based on, that uses evidence to promote and assess other charity organisations around the world. So thanks very much. So we have a couple more events coming up just to finish the year. This Saturday, the Birthing Kit Workshop is coming up. It might already be full, but if it isn't, just check, put your name in the waiting list. And finally, next Tuesday, we've got our election, our AGM. So come along if you're thinking of being involved in GlobalHOME next year, or show support for your friends as well who are. Yeah, thanks very much.